very much, Jane. It's a real pleasure to come to Galway. So I'll start with some acknowledgements. The work I'm going to show is going to be part of a big collaborative project that involves our team in Pasteur in Paris, colleagues in the London School of Hygiene and Tropical Medicine, important field partners in the Institut Pasteur de Madagascar and in Ethiopia, and very importantly, Jane's team here in Galway, and also delighted to start learning from Medea. So in our team, we're quite interdisciplinary. We bring together mathematical modeling and statistical analytics, field-based epidemiological studies, and the implementation of high-throughput multiplex assays in the lab. And we use things like mathematical models, analysis of antibody kinetics, implementation of clinical trials, serological surveillance studies, epidemiological cohort studies, and multiplex assays. And the overall aim is to apply interdisciplinary tools to develop diagnostics for multiple infectious diseases. One thing I know nothing about is mobile health technologies. I think that was quite obvious from my cross-examination of Professor Nugent this morning. So I'm really pleased to be here to learn about what you know. So I've already learned quite a lot this morning. So I'm going to start with some data on the antibody response following infection with malaria. So this is data from somebody in Papua New Guinea infected with clinical malaria and followed up for about 9 months with blood sample taken every 2 to 4 weeks. And following infection with malaria, you generate a complex antibody response to multiple different antigens. These are 3 different antigens. I'll zoom in on one in more detail. The actual antibody is not that important. But what's interesting is the overall pattern of a rapid boost in antibody levels followed by rapid decay in the first 3 months and a slower rate of decay of the antibody response thereafter. And this is a pattern that's repeated following infection with multiple different pathogens. In particular, COVID follows exactly the same pattern of antibody waning. So our approach was to take some of these insights and use them to develop serological diagnostics for malaria. In particular, my favorite malaria parasite is one called Plasmodium vivax. There's a few different species of malaria parasite that infect humans. The main 2 are Plasmodium falciparum and Plasmodium vivax. Plasmodium falciparum is the species of malaria that predominates in Africa, and that is the parasite that is responsible for the majority of malaria deaths, most notably in children and pregnant women. Plasmodium vivax is not found across most of Africa, with the exception of Ethiopia and Madagascar. Vivax is very commonly found in parts of South America, most notably in the Amazon, in Southeast Asia and in India. Vivax malaria, you might have heard about it if you knew somebody that went backpacking in Cambodia and took their anti-malarial prophylaxis and then came back here to Ireland, and then 3 or 6 months later they had a relapse. If that happened, that was Plasmodium vivax. And the reason is because of its tendency to cause relapses. So the process begins with a bite from an infectious mosquito, which injects parasites into the skin. These travel through the skin, through the bloodstream, and reach the liver. Once in the liver, they invade liver hepatocytes, and some of them will undergo development immediately to give rise to an initial infection in the blood. And this is the paradigm for falciparum malaria. 1 mosquito bite, 1 blood stage infection. But Plasmodium vivax is very interesting because it causes these parasites called hypnozoites, which lie dormant in liver cells for weeks, months, or years until they relapse to cause new blood stage infections. And this is the paradigm for vivax. 1 mosquito bite, multiple different blood stage infections because of its capacity to relapse. The big challenge is these hypnozoites in the liver stage parasites, they're impossible to directly detect. They sit inside the liver, dormant, and they do nothing. So you can't detect them directly. So what we've done is come up with an indirect approach. Rather than looking into the liver, we look at the antibody response generated by the primary blood stage infection that came directly after the mosquito bite. So some of the antibody responses are short-lived, some are long-lived, some are medium-lived, and some are long-lived. So what we can do is we can come along and take a blood sample, measure these antibody responses, and then use that to identify individuals that were recently infected. And the hypothesis is that by doing this, we can identify the hypnozoid carriers and target them for better treatment. In order to validate this approach, we implemented a number of longitudinal cohort studies. So in particular, the study design is you recruit 1,000 people, otherwise healthy but living in a malaria endemic zone, and then follow them up for a year and take blood samples every month. And then in every single blood sample, we did PCR to detect the presence or absence of malaria parasites. So in this representative person, they had a malaria infection for these 3 months. The second thing we did was look at the final time point. And in the blood samples there, we measured antibody responses to a large panel of different malaria antigens. And what we're interested in is the relationship between that measurement of the immune response and the time since previous infection. So this individual would have been infected 6 months before the measurement of the antibody response. Whereas some people would have a more recent infection, some people would have an older infection, and for many people we would have no detectable infection at all. And then what we did was develop machine learning tools to select optimal combinations of these antibody responses for doing prediction of time since infection. Saying machine learning is kind of overselling it. You can do this with a very easy logistic regression model, but you can pull in some more sophisticated tools like random forests. And by doing that, we want to identify people who were recently infected. I'm not going to go into all of the details here, but for our purposes, recently infected is infected within the last 9 months. So it's not just saying were you infected, yes or no, it's also dating an infection. And by doing that, we were able to assess our classification performance. And here, this is a receiver operating characteristic curve, which shows the trade-off between diagnostic sensitivity on the y-axis and specificity on the x-axis. And apologies for people that aren't familiar with these curves, but in total this shows that we can get about 80% sensitivity and 80% specificity. And by including additional information from extra antigens, we can get improved classification performance. But there's a big problem of diminishing returns. So this is the underlying technology behind the diagnostic test. The next big challenge is how you treat these parasites. So typically when somebody has symptomatic Vivax malaria, they will get symptoms, and then you can give treatment with a drug like chloroquine or an artemisinin combination therapy. These drugs are very effective at curing people of symptoms, and they knock out the parasites in the blood. But they leave the parasites in the liver completely undetected. And then you treat these people, they go away healthy, and then they relapse and get sick again. In order to treat those parasites in the liver, you need an additional drug called primaquine. And now the combination of chloroquine and primaquine will knock out the blood stage parasites using the chloroquine, and then the primaquine will knock out the parasites in the liver. Seems quite easy. But primaquine is a very difficult and dangerous drug to use. It can cause severe hemolysis in patients with G6PD deficiency. Now, G6PD deficiency is an inherited blood disorder found in about 5% of people in malaria endemic regions. So if you give primaquine to these people, all their blood cells will hemolyze and they're going to be very sick. So you need to be really careful. The next challenge is it's not just a single drug. You have to give it for 14 days. So it's not an easy drug to deliver. So this is the challenge of giving treatment. Now, the next thing that we want to do is we want to combine this difficult treatment with our new diagnostic tool because we have a very specific application in mind. And this is something that we call Plasmodium vivax serological testing and treatment. Now, there's a few different ways of delivering treatment. One is when people get sick. So when people get sick, they come to you, in the clinic, that is. But a lot of Plasmodium vivax, people are completely asymptomatic. People are out there in the community with parasites. So if you want to tackle malaria, you've got to go to the community and find those people. So one strategy is something called mass drug administration, and that's just treat everybody that consents. And just treat everybody that consents to take drugs. And this is a very effective strategy, but you're giving drugs to a lot of people that don't need them. Another strategy that's occasionally used is something called mass screen and treat, where you use a blood stage diagnostic, and then, such as a rapid diagnostic test and look for blood stage parasites. And then you can diagnose the people that have blood stage parasites and treat them. The problem is you're missing all of the people that have these hypnozoites in their liver. So our approach is to use our serological diagnostic test to detect the people with hypnozoites and then target the drugs at those people. And the advantage of this approach is that you're going to target the drugs at the people who need it and minimize the people who you will give drugs to unnecessarily. We're still going to give, because the diagnostic test is not perfect, we will still be over-treating people. So what we did was we developed a simulation model to do simulations of clinical trials. So this is a simulation of a clinical trial in Ethiopia, and with the black line being seasonally varying prevalence of malaria, and the red line is what would happen if we simulated the intervention of 2 rounds of this intervention. Now, on the basis of our work on the diagnostics and the simulation models, we proposed a clinical trial program, and this was funded by Horizon Europe and started 2 weeks ago. So we'll be doing the kickoff in Paris next month. So this is going to be a very large cluster randomized trial in Ethiopia and Madagascar, where we will randomize villages to receive this population level intervention, and some will be in the control arm. It's going to be quite a large trial, and we'll enroll nearly 20,000 participants in total over the next few years, and we're gearing up to get this going. So one of the reasons I'm here is that we need a bit of help. So this is from the mobile health application. So in parallel to the clinical trials program, we're going to need some help on grappling with all of this complexity. Now, Plasmodium vivax is a complex parasite, and I like to think about it as an onion. And if you can peel away layers of complexity, so the first layer of complexity is this challenge of relapses. The next is the problems with the hypnozoites and how to treat them. We've got this problem of G6PD deficiency, as mentioned. Then we also have challenges like this is a genetic disorder that's X-linked, so it's different in men and women. That's something that I'm not going to go into now because that's a much different story. We have age and pregnancy restrictions on who we can treat and not treat. We have problems with metabolization. Some people don't metabolize the drug. And there's other factors, some about which we know and some which we don't know about. If we had a drug that we could just give to people like it was sweets, we wouldn't have to worry about any of this. But we don't. We have a drug that works but is difficult to use, so we need to grapple with this complexity. So in order to do this, our approach is to start building and learning from mobile health applications and try to integrate many of these different steps that we have to do into some sort of mobile health technology app. Now, I don't have a clue how to do this, but I'm learning today, and with Jane and other experts in our consortium, we're hoping that we'll be able to integrate together a lot of these different approaches to help us deliver this new intervention. And I will finish by leaving my acknowledgement slide up and thanking you for your attention.